lot of them come in and they have wiped out their credit rating by, the time they get there. How to get your credit rating back. In addition to relapse prevention, recovery support, the psychiatrist, and family therapy. The family's very involved. All the literature says family involvement, employer involvement, two top things to get people to be able to stay well. Yes, you can.
I'd like to introduce this as A2. This is our sample treatment before treatment building. Now, you view these folks that are living in these treatment buildings, residing here under this, as we were saying, this less restrictive level of care, you believe that they're still patients, is that correct?
They're absolutely patients.
And they're not, these are not by any stretch of the imagination just conventional apartments where people just come and go as they please and they live without any type of supervision, is that correct?
That's correct.
And do you believe, in your professional opinion, this is a necessary part of the treatment for these disabled folks to ensure that the likelihood of a relapse or recovery is greater?
I do.
The relapse is less, and the likelihood of recovery is greater.
I do, and again, it's really just based on the science that the longer somebody stays in treatment, the more connected they are, the more services they get, the better they do long term.
So you believe these will, this is approved, this facility will be a benefit to these disabled folks and preserve the public health, safety, and welfare by ensuring a better quality level of care. Is that correct?
Yeah, I think what people don't understand is that when somebody with an addiction problem goes in and gets effective treatment, that everybody wins. You need this to provide really effective treatment, but when somebody goes into recovery, like myself, like many others, the chances are that 10% of people in this room actually are in recovery or have an addiction. When somebody goes in and they get well, they win. The family wins. Their employer wins. The healthcare system wins. They're not at the ER, clogging up the ER. Everybody wins.
And I think you indicated that there were some articles that kind of backed up your thinking, or that you had reviewed that you were relying on. And I'm going to show you a couple of exhibits. If you could just identify these articles and just briefly describe them.
So A3 is an article by Jim McKay, and it's in a peer-reviewed journal called Addiction. It's probably one of the top 5 journals in our field. And Jim McKay has probably done the most in the country in terms of continuum of care, long-term care, including check-ins and telephone monitoring. So he's probably done the most research. He's a full professor at Penn. His article talks at length about the disease management, and it cites, the good thing about this is it's not a meta-analysis, but it cites about 15, 20 different long-term studies, 1 to 5 year studies that show that longer time in treatment is better. So that's A3. A4 is an article from Betty Ford on their Focus Continuing Care Protocol. And I actually worked with Jim McKay on this and published with him and John Casciola. And what this shows is that what we implemented at the Betty Ford Center, because that was a flyaway model and people would leave there and not have this great continuation of care, was that we implemented something where people called up the patients after they left, and they called every week for 4 weeks, and then they called every other week. And what happened with that is the support that they got from that, just having people check in with and who they knew. The people who participated in that longer, were much more likely to stay sober and to continue to do well. So,
And while I'm presenting these, so I'd like to introduce A3 before evidence. And just briefly, one of the things I wanted to touch on with you was security. Do we have any type of plan for security at these facilities of any kind?
I thought this was a good neighborhood. Security, do I want security guards? Do I think I need security guards? No. But we do have plans for security in the sense that people can't just willy-nilly leave and go, walking down the street and whatnot. When somebody wants to leave treatment, and a certain small percent, hopefully very, very small percent for us, will leave. The last program similar to ours that I ran was Sierra Tucson in Arizona. We had an 8% of people left before their treatment course was finished. And they have to come to you and they have to say to you, I want to leave, I'm not happy here, I don't like the food, I miss my wife, whatever they say. We try and keep them in. But if they don't want to stay, then we get transportation for them, or we get their spouse to come in and pick them up. Also, just as part of the safety for the patient as well, because many of our folks will have co-occurring disorders. We want to keep a very close eye on them and their symptoms. So there are room checks every hour at night. There's grounds checks every half hour, every hour and a half hour. So we do keep very close track. This is not something where somebody can go missing for half an hour and nobody knows. That's not the way we'll run.
Who's responsible for the check?
Yeah, the grounds check, well, let me start inside. So the room checks will be the nursing staff, and what's called...
Excuse me. Are you talking about the hospital, or are you talking about the 4 buildings?
I'm talking about both.
Can you differentiate that?
Yeah, okay.
Make it a lot easier, I think, for the board to understand what's in the hospital and what's in these 4 buildings.
Yeah. So we have nursing staff in both, and we have recovery support staff in both. Okay. Typically, it would be more nursing staff in the more acute setting, the 125 bed, and they do room checks where they check every hour and go into the room. We also will have, motion detector monitors, cameras, and whatnot out. We have, usually the recovery support person will go and do the outside perimeter check. In the other buildings, it will be the living supervisor that will do that, and they typically are a recovery support staff or a coordinator, a case manager coordinator.
Continue.
Thank you. I believe you were, Dr. Shields testified, but do you also believe that in this particular location, meaning Gloucester Township, there's a need for this type of facility?
I do. I think there's a huge need. I mean, if you just look at overdose death rates, so in the past 10 years, overdose death rates from heroin have quadrupled in the country. So you start there. The overdose death rate in New Jersey is 3 times the national average currently, and Gloucester County actually is the 4th highest level of overdose death rate. All the literature shows that people who stay in treatment longer, who are engaged more, who are monitored, and that includes with drug screens as well as just check-ins and things like that, they do better. So I think that there is a need for that. One of the issues about having these 4 buildings is that with the volume that we'll do there, it really enables us to have the kind of staff we need. So a smaller set of buildings, or just the 125, wouldn't actually give us what we need to be able to have the psychiatrists we want to have. For drug treatment center, we're actually pretty heavy, because of my background probably, on psychiatry as well as medicine. So we will have psychiatry staff, medical staff, psychiatric nurse practitioners, general nurse practitioners, and whatnot, and that enables us to do that. So people need a place to go where they kind of sink their teeth into getting into recovery, learn, they can transition from one area to the next and do well. One of the problems with treatment today is that nobody takes responsibility for the whole course of treatment. The likelihood that a patient leaving, for example, Betty Ford, and Betty Ford's a great program. I've worked with them for years, and the likelihood that somebody coming from Betty Ford, coming back to Philadelphia, for example, and this actually happened to a very close friend of mine who was transferred out of Betty Ford back to Philadelphia with the names of 2 places to go for outpatient treatment. Now, he happened to have slight dementia. He was 72 years old, didn't have a car. They were both an hour's drive from Philadelphia where he lived. And he died about 4 months after he was out of there. The continuum of care, the structure that folks need, and that continuum of care, that's what I don't think we see anywhere else, and that's what I think is so necessary.
So is it a fair statement to say that the size of the facility and these 4 treatment buildings are required to make the facility medically effective or to serve a therapeutic purpose?
I believe the size is, yeah. Again, it enables us to have the staff we need, and it also enables us to serve as many folks in New Jersey as we can.
Then finally, do you believe that this facility, if it is approved, will be an important component of Gloucester Township and serve the health, welfare, safety, and morals of the township?
I think it will do that, but also I think it will be a national example of really the best-in-class treatment.
Thank you, Dr.
Yeah.
Okay, sure, go ahead.
Yeah, Dr. Tupple, you A2, your sample,
Yes.
where are these activities held?
Okay, so in the building for the 125 or the 4 sites?
Yeah, well, what's on your schedule? Is this the schedule for the inpatient, or is this the schedule for the 4 buildings?
Yeah, it's tough to say. So this would be a little bit more.
No. It's not tough to say. It's either or. Is this
Okay.
for everybody, or is it one building, both buildings?
Okay, let me tell you why I say it's tough to say.
Okay.
Every patient's different.
I always got the impression
Every
that this was all in the 4 buildings.
These are sample schedules. This absolutely could be in the 4 buildings. But again, these are sample schedules. Depending on patient need, depending on what they need. Somebody might need psychiatry that's not listed here. They would definitely get that. Somebody might not need something else that is here. So this is all could happen within the 4 buildings. Now let me tell you, within the 4 buildings, the patients will be living in the 4 buildings. We'll have supervision staff there. They will get group therapies. They will get didactic sessions. They could get individuals there. They could also go into a separate building for larger group things that we can't fit in that place, so yes.
Would that be every day while they're there?
Yes.
It would be every day.
It would absolutely be every day while they're there, yes. Yes.
What is the minimum amount of treatment that somebody would need in order to qualify to stay in these buildings?
If somebody's living in our sites, in those 4 buildings, they're getting treatment all day. So they are not, the free time, they may have a half-hour free time in the morning, an hour at night, but they would get full treatment.
With all due respect, that's not what we were told at the last meeting.
Yeah, I'm sorry.
It wasn't you.
Yeah, I know.
But the representative said that somebody could go as little as 1 hour and still live there.
That's not accurate, and it was a mistake.
What is the minimum that somebody would have to attend on a daily basis in order to qualify to live there?
8 hours.
8 hours
Minimum.
a day?
Minimum, and it will be more.
We were also told that they were able to go and come, they can go to work. They can't go to work?
No, they cannot go to work and live there, but by the fact that they're living there, they're in treatment all day.
They can't go out to dinner?
If they're doing really well, they have no drug use, and their spouse is in for family therapy with them, they may get a pass to go to dinner with them. When they get back, we'll do a urine drug screen to make sure they didn't use, but that's a perk. That's not
You're saying that somebody living there will get 8 hours of treatment a day?
Absolutely.
How many days a week?
7.
But they are free to go different places, correct?
They are not free to leave without their primary therapist approving it, and they have to approve for a reason, and yeah.
Where could they go?
They could go to dinner with their spouse
Could they go to work?
and live in those buildings. No, they wouldn't be attending the
What
treatment.
we were told last time.
We were told differently last time.
Every time the applicant comes here, it's a different story.
All I can tell you is I'm designing the care for RCA, and that's what's going to go on in those buildings. Those people that live there will not go to work, and they will not be hanging out watching TV. That's not going to get them better.
What about court-mandated people?
So we may get some people that are mandated by the court because of like a drunk driving charge or whatnot, but that will not be the mainstay. We may get people that have bracelets on or ankle bracelets on from the court, so that's a possibility. But we do screen everybody for any kind of violent crime or anything like that, and we are not going to be court-ordered. We're not going to go out and try and get court-ordered contracts and whatnot.
Again, one of the hearings, we were told there would be no court-mandated people there. No, it wasn't you. It wasn't you. I'm just saying.
It's okay. I wouldn't want to deny somebody care because they had a drunk driving charge and the folks said they have to come to treatment. I wouldn't want them to not be able to get well. So.
Now, what about the people outpatient, the people that don't go into this facility?
Yes.
Where do they go for treatment?
We have the building there, the outpatient building's there. They're in a separate building, and there's a couple different levels they can come in. And again, somebody may come just to outpatient. They may not need this, right? But the outpatients, there's a couple of modalities, and it'll be a different building. And that would be traditional outpatient, and typically that's one individual session a week in one group. Or it'll be intensive outpatient, and that's typically 3 hours at a time, and it's 3 nights a week. So typically it's after work, so those folks are working. They're not living here, they're not in those 4 buildings.
And what about the cost of staying there?
The cost of staying in the 4 buildings? Right now, we're talking with all different insurers. We're trying to get rates that we can live with, that we can provide the treatment that folks need. There's 100 ways that we can look at that, but truthfully, it's not my bailiwick in terms of the financing of it.
Who could answer that question? Well, we'll get to it.
We'll get to you then.
I'm political, so.
At the last meeting, we were told $200 a night.
Sir?
At the last meeting, we were told they would pay $200 a night plus treatment. And we were told that no insurance company has approved this yet. Is that correct?
I don't know, I've never planned for them to pay 200 a night, and I don't know, insurance, you know, it depends to what state you're in. Some states.
No, we're talking about New Jersey.
Okay.
We don't care what happens in other states.
Yeah, well, again, I'm not negotiating the contracts, so I can't answer, yeah.
You can't answer.
I don't want to, yeah, you got it.
Now, I guess you could answer though, what % of your patients, inpatients, would avail themselves to this facility?
Based on the science, what the science says, I hope 90% of my inpatients avail themselves of this.
90%?
I hope 90% avail themselves.
That is what you're hoping. I'm asking what, in your experience, you're the professional, what % do you envision of your patients using these 4 buildings?
Well, you gotta know, there's never been anything like this before. But I would still say, I would hope for 90%, but I would envision 75%.
90% go there if you have 125 beds. I mean, it seems like impossible.
Well, it depends
I'm
how
not
long.
good at math. But
Yeah, right. But it depends how long they stay, you know? I will tell you, I'll give you the model that I'm thinking of when you ask that. At Sierra Tucson, which was residential, people stayed for anywhere from 30 to 60 days in the intensive part, and then about 75–80% of them went on to halfway houses around the country. But it's never been, and those were halfway houses, these are not. It's never been all on one campus. The reality is that 90 days seems to be a break point in all the literature studies. So if I can get somebody in intensive treatment, whether that's the 125 and then the 4 buildings, or whether that's the 4 buildings and then intensive outpatient, if I can keep them for 90 days, I got a better shot at them having to get sober and then.
In the inpatient.
No, not 90 days in the inpatient, 90 days, right, in intensive care.
In 4 buildings.
In intensive care.
But you still haven't given me a percentage.
I just said 75%, I think.
75% of the people that you treat in the main building will wind up living in these 4 buildings?
I can't really, yeah.
Excuse
Let me answer as a
Let her
clinical.
answer the question.
I'll answer clinically. 75%
Would you say this to a
of
cancer
people.
patient?
Excuse me, sir, you're out of order, please.
I think you're out.
Please, no, you're out of order right now. You'll have your turn.
Can't wait.
Thank you.
I can't wait.
So I can't guess. I will tell you 75% of people will absolutely benefit from doing it. I will tell you 75% of people will absolutely benefit from doing it.
75% of the people will live in those 4 buildings?
I just said 75% of people would benefit, but I can't guess.
What does that mean,
I can't
benefit?
guess.
So you have
What-
no idea how many people will go from your inpatient into these 4 buildings, is that correct?
That's not correct. I have no idea means no idea, you know? I have some
I'm just
idea.
saying, you had no idea. I'm just
I'm
trying
telling you, I
to.
can't guarantee it.
Right?
All right. Let it go.
You don't know.
You don't.
Let it go.
Okay.
I have a question.
Go ahead.
Will there be any instances where the people that are living in the 4 buildings and the people in the main treatment
125.
area, will they get treatment together?
I don't believe New Jersey's state licensure regulations would allow that.
Pardon?
I have to check that. I actually don't know if your state regulations.
Saying no or yes?
I'm saying I don't know if your state regulations would allow that. Typically, no. Let's say no. If you want to, you know.
I'm looking at the floor plan for the first floor building, and it doesn't seem like you have enough area. The number of people that would be living in a particular area and the size of the group area
Within
seems to
the
be much smaller than
within
the
the 4
number of
buildings.
people you have, like, for dining areas and apartment areas.
Okay. Okay. So what's the question?
So where would the rest of the people get the treatment?
There's 4 buildings that are residential. In those, there's 4 buildings that we're talking about, right?
Yeah.
In those buildings, they will get recovery support staff, they will get individual, they will get some groups. They will also go out to a separate building, another building right across the, I think he's gonna pull it up now, right across the way and get their more intensive treatments, their primary therapy group, their art or maybe music therapy, their individual sessions would be in another building.
And the people from the other facility,
The 125, they get all their treatment in the 125 building.
and they wouldn't be in that building where these people are
That's
getting
right.
treated.
That's right.
Thank you.
In the evening, if someone goes out to dinner with their spouse
Yeah.
and they come back, they're checked, who does the bed check at night for all the people that are in the buildings?
The people in the buildings will be a recovery support person or case manager, or in the larger building, usually sometimes it's a
You would
nurse.
have a bed check at night? at a
Yes,
certain
every
time?
hour.
Every hour?
Every hour.
In the buildings? the
Yes,
four buildings?
yes.
Thank you. Yeah, Kevin?
After the 90 day, after you come out of the 4 alcohol pod,
Okay?
after you call it pod, when they come out of there, what's the rate of relapse?
When people get 90 days of treatment, I'm just trying to think of the literature on this. 90 days of treatment, see, 4 weeks of inpatient treatment, I'm going to tell you the relapse rate is 90% in 6 months. When people get 90 days of treatment as residential, it's going to go down about 20%.
So you're still looking at like a 70%.
That's right. That's why it's so important to have the other outpatients, so that when they go home, they have the intensive outpatient and then the continued outpatient.
Okay, so it's 90% out of the hospital, and then it would be 70% out of the pod, out of the other component of this.
If it's followed by nothing else. That's why we need the full continuum of care.
Good.
I have some questions. How many employees? It's been indicated that there's 97, but there's been all kinds of inconsistencies in some applications. I want to think you might be the appropriate person to get that on the record.
I can't put that on the record, Brad. I actually don't know that yet.
Can someone in
We'll address it, yes,
You
we'll
will
address
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 it.
it.
Yes, Mr. Wilkie, no. But-
It doesn't have to be.
Go ahead.
I just thought you
Yeah,
might be the
sure.
appropriate person. I
Okay.
apologize.
I can give you the number for the 125 off the top of my head, but the other one I can't. All of our programs are about a 1.3 ratio, 1.3 staff to 1 patient in the detox and the most intensive, most structured area.
1.3 employees to each patient.
Yeah.
So since been a new development here where the patients in the treatment, residential treatment centers will not be able to leave. They would then not be they would not be allowed to have a car, or they wouldn't have a need for a car in the facility?
They wouldn't have a need for a car in the facility, but I just want to be clear that I can't stop a patient from leaving, right?
Right.
Yeah.
I'm looking at it from,
As part of their treatment.
just
Right.
to qualify this, I'm looking at this from the engineer's point of
Okay.
view. I think parking and things like that, so.
So we greatly encourage
So I'm
patients.
trying to figure out the parking amount this facility's gonna
Yeah.
be. So-
And I think somebody else knows more about that than me, but I will tell you that we absolutely encourage patients not to bring a car, not to park it there, and they can come and go. In fact, they can't say, I'm gonna, even if they come, they can't say, I'm gonna meet my wife for dinner. The wife or husband has to come and take them.
Great, okay. And, so there's an unknown with the amount of people that come from your facility going into the residential treatment center. Would it be possible, or would you be in your business plan to also recruit from, say you're not getting the census for your facility, would you be looking to get people into those centers from other treatment facilities in the area?
I would be looking to help anybody at any level of care across that continuum all the time, regardless.
Any other questions? Yes, sir.
You said it's a privilege to leave. They need
A pass.
a privilege to go to dinner or even to visit home or family. Come back. They will be drug tested when they come back.
Yes.
Substance tested.
Yes,
Who will do the substance testing one?
the recovery support staff do it.
There'll be qualified medical staff to do that?
Yeah, absolutely, absolutely. It's for the safety of the other patients too.
Anyone else?
Do you have your license in the state already?
I don't, I'm not licensed.
No, not you, the facility. Have You've been licensed by the state or applying for a license?
We're applying for a license, yeah.
You don't have your license yet.
We're not open, we're not built yet, so we can't get a license until we're,
So the state has never seen these plans.
we've talked to the licensing folks, and we're developing these in conjunction, but we can't apply for a license until we have the building and we've made it, yeah.
Thank you.
Anyone else? Yes, sir.
I have one until you just made a comment. So what happens if they do leave and they are tested positive?
It's a good question. So the interesting thing about this field is the only field in healthcare where you get kicked out of treatment for having a symptom of your disease, right? If they come back and they test positive, if they talk to us about it first, if they say, look, I just want you to know I had a glass of wine with dinner, it's a therapeutic issue. We bring it up, we tell them they have to bring it up in group, they talk about it in group. The time when I look at safety for the rest of the community is for some reason if they come back and they bring drugs back. Now that's a really different issue for me for the safety of the community. So no, I won't kick people out because they have a relapse, but it really depends on the situation.
Also had a question. If I'm going to ask it properly, you indicated that there's a possibility of 90 days treatment overall. So who determined, and you can't guarantee when someone's going to decide, this is not for me, but say they want to stay there, they want to continue it, when and how, in your opinion, is it determined that you have to leave now because we have other needs for other people and you're okay? When did that happen?
It's a great question. So what the literature says about that is that somewhere after about a fourth month, and this is not specific to substance abuse because there's not a literature on that, but in mental health and whatnot, that you get this kind of institutionalization that sets in after about 4 months. So you do find an issue where being in kind of a residential, very structured community is not beneficial to the person after a certain amount of time. So we would be looking at the guidelines for that and deciding when they go. You know, what the field doesn't have, because we really grew out of a very paraprofessional field and are only now really medicalized and covered under healthcare, is we don't have, like the rest of healthcare has, a priori decision factors of, okay, when you meet this criteria, you can be discharged to intensive outpatient, and when you meet this criteria, you can be discharged to traditional outpatient. But we're going to try and develop those. We've gotten together a scientific advisory board of about 20 of the top people in the country. We're going to try and develop that, as well as outcome systems, and show what the field should measure and what we would kind of report in terms of outcomes as a field.
Is there a possibility that you have to kick somebody out because I could almost imagine someone maybe developing be symptomatic that they have to stay here. I can't leave because, and they want to stay and they're able to stay because maybe they're independently wealthy and money is not an issue, and I can't leave because psychologically that if I leave I'm going to relapse. How does that?
Yeah.
I don't even know if you have an answer, but it's a thought I have.
Yeah, it's an interesting question, actually. So there's people who have been in treatment in these therapeutic communities for 6 to 8 months and go out and relapse. It would really depend on the patient. If this is a person who's had 6 months of treatment residentially a number of times and they still relapse, I'd be inclined to keep them as long as I feel we're doing well. But the other piece of it would be when they leave here, they're not discharged like, okay, here, go home now, you're doing great. They'll be sent to a living situation, whether it's their home or whether we help them find a place where they'll then hopefully continue in intensive outpatient. That would be our goal. And they would come 3 nights a week. And they may have some of the same people in their group from inpatient that are there. And there really does come a time with residential treatment and outpatient treatment where somebody is there longer than everybody else. They see their group of friends, their group of 8 people that they are bonded with. It turns over 2-3 times and they start seeing that they're the only one that's not moving on, and tends to incentivize them to move on. But it'd be a case-by-case basis.
What would be the minimum amount of time, the minimum stay in the buildings?
I'm not going to have a minimum stay. I'm going to plan on 1 year of treatment across the continuum of care, but I'm not going to have a minimum inpatient or a minimum 4-building, the 4-building ones. I'm going to try and keep them there while it's, as long as they're doing well, if they're benefiting from it. You know, I'm not gonna have a minimum or a maximum.
Okay, no minimum. Okay, thank you. Anyone else? Continue, Council.
Thank you. Thank you, Dr. Freeze. Mr. Wilson. You're previously sworn, correct?
Yes, sir.
And do you have any qualifications or licenses in the state of New Jersey?
Yes, I have.
We could stipulate he's
We-
testifying.